Thank you very much for these kind words. So we have spoke a lot about biology. We're going to speak now about hardware, about prosthesis. And in the next minute, this is what I would like to share with you. When not to attempt at re-repair, the concept of non-functional shoulder and the concept of shoulder imbalance and the treatment options. Because basically, when you face a re-tear, the attitude of the surgeon should be the same than in front of a first tear. And there are many reasons not to reoperate a failed cuff repair. If you have no tendon, because resorption of the tendon like this, with proximal of the migration of the humerus, do not try to re-repair. If there is no good bone with a cyst like this in the greater tuberosity, do not try to re-repair again. If there is muscle atrophy, no infraspinatus, no supraspinatus, just look at your patient from the back. Don't try to repair those patients. Because we know that in addition to atrophy, you may have fatty infiltration. So look at the imaging studies, MRI or CT scan, and we know that this fatty infiltration, according to Christian Gerber, is non-reversible. So do not try to repair those tendons with no muscles. This doesn't work. It has been shown nicely by Christian. That despite successful tendon repair, the fatty infiltration does not reverse. Now, do not try to reoperate a cuff tear and do a re-repair without having an X-ray. An MRI is not enough. Why? Because you need to look at the Hamada and Fukuda classification. And you can do an attempt at repairing only if it's a stage 1 or 2, which means decrease acromial space, but not a stage 3, 4, or 5. That's very important. Do not try to repair again this kind of re-tear. And this is nicely shown here on this AP view. You can see that there is superior static subluxation of the humerus. And there is no way that either with a patch, whatever you want, that you will be able to reload the humerus down in this situation. So do not try to repair those patients who have a proximal humeral migration. Now, also look on your actual cuts, because you may see an anterior static subluxation. And this is not a good indication for a re-repair. And finally, when you have a pseudoparalyzed shoulder, which is for me an abduction less than 90 degrees, and with the anterior superior escape of the humeral head, don't try to repair those patients. So you see, in summary, there are at least 7 good reasons not to attempt a new tendon repair or transfer, or even a tendon transfer, when you have no tendon because of resorption, when you have no muscle because of atrophy, fatty infiltration, when you have no good bone because of osteoporosis, when you have no good joint because of arthritis, and when you have superior static humeral subluxation or anterior humeral head subluxation, and of course with the dynamic humeral head subluxation, which is a pseudoparalyzed shoulder. So finally, what are our treatment options for those patients? They are listed here, and you know all of them. I just want to consider something for you. This is the concept of functional and non-functional shoulder. It means a good balance or lost balance of the shoulder. This is a pseudoparalysis. You see these two patients as the same cuff deficiency, the same cuff tear. On the one hand side, you see that the patient has full elevation, he has pain, but he has a complete elevation of the arm. On the other side, this patient has a pseudoparalyzed shoulder that does not recover with rehabilitation. So this kind of patients, you see, who have a real pseudoparalyzed shoulder, they are not good candidate for the re-repair of the cuff. And of course, they are candidate for shoulder replacement, and this is a reverse prosthesis. So for those functional shoulders with the re-tear, you can do many things. It doesn't matter. But for the shoulders which are non-functional, you should consider only the reverse or the reverse with the transfer or the transfer. So let's see what we can do for those patients. This is going back to the basics. Steve Burkhardt was here, and he showed us that there are two force couples in the shoulder, one vertical, one horizontal. The problem is that the vertical muscle balance is progressively lost. And what we operate on are not cuff tears. Most of the time, it's cuff wears. So this should be taken in consideration. And when I see all those patches under the arch, and I imagine the shoulder moving with all these staples going out of the cuff, I'm really afraid. Because I must say there is a contact between the acromion arch the CL ligament and the cuff. There is no space. So there is rubbing of those patch under the arch. So by the way, what we operate is cuff wear, and you see that you can have a loss of horizontal balance. And we know that we have many muscles to do internal rotations. In addition to the subscapularis, we have the latissimus dorsi, the teres major, the pectoralis major, and the subscapularis. And we have only two external rotator muscles, the infraspinatus and the teres minor. So if you lose two of your external rotator muscle, you have lost your horizontal balance of the shoulder. And this is very important to understand, because the clinical presentation of those patients with a failed rotator cuff repair is the same than when you face a primary cuff tear. You have four clinical presentations possible: a painful but functional shoulder, an isolated loss of active elevation, which is a classical pseudopolarized shoulder, an isolated loss of external rotation, and a combination of loss of elevation and external rotation. Gilles Valche has taught us that the main cause of the pain in those patients with a functional shoulder was the biceps, and that we could solve the problem easily just by doing a biceps tenotomy, or today a biceps tenodesis. This patient has a cuff repair, and the biceps was left in place. All we did is just to make a biceps tenotomy, and 15 years after the surgery, she is still happy. So can you believe that? This is a very low-cost surgery, very efficient, and that every other procedure should be compared with. Now, this was for a functional shoulder. The problem is that when you have a non-functional shoulder with a classic pseudopolarized shoulder, the solution is the reverse. There is no other solution. Personally, I'm not able to restore the motion of this patient, neither with a cuff re-repair, neither with a muscle tendon transfer. This patient is very interesting, because the first time he came to see me, he had a cuff repair, and I didn't understand why he was coming to see me, because he has very good elevation. However, as you can see, he has no active external rotation with the arm outside, and even worse, he has no active external rotation in abduction. He has a hornblower sign, a lag sign, etc. So he's bothered in his daily life by this problem. And the shoulder is not even painful, but he cannot use his hand just because the forearm is swinging toward the trunk. And I call this patient ILER. And of course, the solution in this case is to do a latissimus dorsi transfer or a lepiscopo in women, because they don't have a good latissimus dorsi. Can you go back one slide, please? Yeah, this patient is a different animal. It's a clear patient, which means she has lost active elevation and external rotation. So in this case, both muscle balance are lost, and the solution is to a combined operation where you do the reverse plus the tendon transfer. So basically, you see that in the 4 groups of patients, only one is a functional shoulder. The 3 others are non-functional shoulder with pseudopolarizes, either in the vertical plane or in the horizontal plane or in both planes. And for this patient, the treatment is different, of course. So these are my indications for a failed cuff repair today. They are not different from a primary cuff repair. You must consider a non-functional unbalanced shoulder with pseudopolarizes, or a functional balanced shoulder with only pain and weakness, shoulder weakness. Now, if this is a functional shoulder, look for the biceps, because if the biceps is still present, with a very small operation, you can solve the situation, and then you can play with your patient and do a partial repair, a transfer, a subscapularis augmentation, or a balloon, or whatever you want. I mean, a patch, you can play with what you want, but don't forget to kill the biceps, because this is the major cause of pain in these patients. Now, if your patient has a pseudopolarizes, which means a loss of vertical muscle balance, he needs a reverse, for sure. If he just have a loss of active external rotation, he just needs a tendon transfer. And if your patient has a loss of horizontal and vertical balance, you need both the reverse and the transfer. So that's my take-home message. The 3 main contraindications to a re-repair or to a tendon transfer are the chronic pseudopolarizes that do not recover with rehabilitation, the static anterior instability, and the static superior instability with the migration of the humerus, and these are indications for a reverse. And the reverse is really the solution for the pseudopolarized shoulder, and you can add transfer if you want. Now, finally, the last thing that I would like to tell you is that beware of low-grade infection after a failed rotator cuff repair. We recently published a paper where we evaluated 69 patients with a cuff retear and that we reoperated. And we found that in 36 patients where we did biopsies, they were positive in 1/3 of the cases. Of course, Cutibacterium acnes in the majority of the cases. But why do I say that? Is that because if you do a reverse and then you have an infection of your reverse, you lost the game. Thank you for your attention.